Hi, I'm Dr. Julius Few, and I'm the director of the Few Institute in Chicago and in New York. And it's my pleasure to introduce some of the concepts behind the Silhouette Instalift and really the first FDA-approved absorbable suture suspension lifting technique for face and neck rejuvenation. And I have a couple of patients. I'm going to demonstrate the differing techniques. I'm going to focus on really identifying asymmetries prior to treatment, different techniques that can be used to make the face more symmetric, using aseptic technique for placement of the sutures, applying the bidirectional movement of the sutures, and then ultimately some tips and tricks on safety and aftercare. So with that, I'm going to turn our attention to our first patient. As you can see, very pretty face, she has a number of features that are important to kind of note prior to the placement of the absorbable sutures. And number one, and this kind of jumped out to us when we were reviewing photos, was the asymmetry in her left upper lip. And you can really see between the left upper lip and her nasolabial that she has a bit of hyperdynamic movement of her zygomaticus on the left side. And I'm going to ask her to smile for us. So you can see that she pulls up a bit more. Give us a big smile, big smile. There you go. So she has more vermilion show. She has more upward movement of the lip on the left side. And this is going to be important because when we place our sutures to help lift up on the cheek, on either side, you can see where potentially there could be some asymmetry. And so what I plan to use is a neuromodulator, either Dysport or Botox or Xeomin, and I will place it at the base of where the zygomaticus comes in and the levator labii, so that I can help calm that part down, and I think it'll ultimately give us a better rejuvenation with our Silhouette Instalift. In terms of placement of the silhouette, I think there are a couple of important points to kind of note. What I try to do is look at the pre-gel sulcus and then the post-gel sulcus and identify the gel, and then just at the beginning of the pre-gel, that typically is 0.1 for movement. So I want to see this actually move up and back so that we get the beginning of our vector movement for the lower face. And then using 1, 2, or 3 sutures, we can, and again, depending on the patient, we can actually place sutures up just above the nasolabial fold so that we can get mid-facial movement back and again up. Now, where the Silhouette, I think, is unique as compared to the barb sutures of the past, it really is a bidirectional movement. And so by bidirectional, what I'm referring to is a way of really three-dimensionally rejuvenating the cheek, because we're not just moving the tissue back and up, we're actually moving the tissue back, up, and projecting forward. And because the cones are positioned in physiologically a certain way, it allows for the cheek to actually, especially at the malar eminence, to project forward. So this conceptually is a big, big advance in terms of suture lifting, and I think it's really important. Another point which you're going to hear me kind of emphasize multiple times throughout this program is the idea that these are fully absorbable. So they're made up of PLLA, polyl-lactic acid, and that's important because it's a material that we know is biodegradable. It's used extensively in surgery, and we know that it is safely applied. So that's another advantage when we look at treating our patients, that we can tell them that typically in about a year we will see roughly the majority of the product gone and replaced by the patient's own collagen. So these are some of the important points. I'm just going to go ahead and do some markings on one side. I typically don't do markings now, but for the sake of illustration, I'm going to highlight the markings just to show where the sutures go. So to begin with, and I'm going to ask you just turn your head just a little bit more. Great, and chin up just a little. Perfect. Is that okay? Mm-hmm. Okay, good. So as I mentioned, my first point of exit is going to be typically 5 to 10 millimeters past kind of the point of movement. So my point of movement, as I mentioned earlier, is right at the beginning of the jowl. This is the point that I want to see move back and up. So that means that my point of exit is going to be just about here. So I'll anesthetize this point, and then using the rulers that actually come with the sutures, we can actually, and I'll just show this on camera here. There we are. So as you can see, depending on which suture we're going to use, and they come in 8, 12, and 16 cone sutures, we can decide really how far away from our entry and exit points we really need to be, and then use that to kind of map out our treatment strategy. So in her case, I'm going to use an 8 cone suture for the cheeks and a 12 cone suture for her jawline. And so we have a nice diagram showing just how far we need to be to make sure that we have room to clear the cones. And so what I'm going to do here is, based on the fact that I want to use the 12 cone, which is the middle suture, I know that I want to be out at roughly the 7 centimeter mark right here as my exit point, so I have plenty of room to clear the cones. And then on the ruler, there's a 0, which hopefully you can see right here. So this is the 0, and that marks where my entry point will be for placement of my initial suture, and then I know my vector of movement is going to be in this direction. So we're moving out that way. And so then with the 0, the beauty of the bidirectional cones, you can actually change your vector of movement depending on your treatment strategy. So this is somewhat of a lazy L for placement. And again, in terms of my suture placement, I'm going to come up into the hair here so that I have plenty of room for clearance for my 12. And so that's going to be my initial point of placement. And this is our vector of movement. So the second for her will be right here, because I know that really I want to see the nasolabial move back. And so again, in accordance with what I mentioned earlier, this is going to be the exit point for the suture. And because we're going to use an 8 cone suture for the cheek, we don't have to go quite as far out. So I'm going to actually mark at 5 centimeters for my second point of placement. And for this, because my assessment of vector movement is really more in this direction, it's going to be almost straight. I'm going to angle just a little bit, but not very much. And my second point of exit is going to be right here. Now, because by my assessment, I don't think that she has a lot of midfacial ptosis, I'm not going to place 2 sutures here. If she had a bit more, I would. And I may actually on the opposite side, just because I feel her nasolabial is a bit heavier on the left side. I may place 2 on this side, whereas on her right side, I'm only going to place 1. And then that sets the stage for our up and back lifting, and at the same time increasing cheek projection. So with that, I've marked this particular side. The other side I really don't need to mark. You'll see how I typically will do injection on an unmarked side, and then we go from there. My next step in the process would be placing local anesthesia. So it's really important to keep in mind when we do our local anesthesia, and the local anesthesia of choice for me is the 1% lidocaine with epinephrine, 1 to 100,000, that basically we anesthetize just our points of entry and exit, but we're not putting any local anesthesia in the actual track of suture placement. This is really important for a couple of reasons. One, it will increase unnecessarily your risk of bruising and swelling. And then the second issue is that it will give a false sense of security in terms of the zone of placement. These sutures are meant to be placed in the immediate subcutaneous space, so just under the dermis. And that plane is largely avascular, and it's free of a lot of the sensory nerves that would give patients discomfort. And so when you use the sutures appropriately, we typically find that it should be largely a painless procedure. And in turn, it's really a small amount of local anesthesia, so we don't have to worry about patients getting a lot of epinephrine response systemically. The process is very well tolerated, and it should be really a comfortable treatment experience. So with that, I'm gonna transition to placing some of the local anesthesia, and I'll demonstrate that as well. So she's already, I should note that she's already been sterilely prepped with chlorhexidine. I think it's perfectly fine to use betadine, but this is largely an aseptic technique. And so again, I begin by placing the local, typically half to 1 cc at each location. You doing okay? Mm-hmm. Good. Sorry, that's the sensitive one. That's the sensitive one. There's no way around that one. Okay. And then we're gonna, for the hair. Now I think it's important to feel for the superficial temporal vessel, in particular the artery. And I feel it right here. So it's about 7 millimeters behind my point of exit. Yeah, so you can feel it pretty nicely here. So I know that I want to stay off of that, obviously, so I'm going to make sure we go just a little bit anterior in our placement. Sorry. There we are. Good. So that takes care of the local anesthesia for this side of the face. And you can see it's pretty expeditious. The process is manageable. The area just above the lip is probably the area that patients feel the most. So I usually do that not as my first point of entry, but kind of in the middle, because I don't want to alarm them by treating the most sensitive spot first. So that's that side. So now what we'll do is I'm going to have you we'll turn the other way. Go ahead and turn all the way to the right. Perfect. So because I know based on her right side approximately where I want to go in terms of my points of entry and exit, obviously typically we see venous branches that are coming off like this, so I'll typically go either in front or behind that point as my starting point. And so in this case I'm going to go just behind it. Doing okay? Mm-hmm. You're doing great. Sorry. Same thing on this side. I want to feel for her superficial temporal. Go just in front of it. I'm sorry. Doing great. And then we'll do that sensitive one last. Apologize. There we go. Good. And so the beauty of actually the cheek is by covering this zone here on the lateral aspect of the malar eminence, what we're doing is actually allowing for in parallel suture placement. I can place 2 or 3 and going in close but not the exact same entry point to get our desired desired effect. And you can really see, if I'm going to turn her back, you can see now the difference in her nasolabial fold, where she tends to be a little bit heavier on that left side. So we may place that extra suture just to get the lift we're looking for. Typically what I will do is I'll look for the initial blanch of the epinephrine effect, which we can see nicely here and here. And that tells me that in general we're at a point where we're ready to begin. And so with that, I think we're gonna get ready.